Welcome to the Rethinking Pain podcast by Lynn Health, where health and science meet. Over 80% of people experience life-impacting back pain at some point in their lives, while the USA alone spends upwards of $49 billion a year trying to get rid of it. What's causing all this back pain? Joining us today are Charlie Merrill and Zach Gabor, two seasoned and passionate physical therapy experts. Together, they'll dive into why chronic back pain may not be what you think it is. Zach is a Boston-based physical therapist and educator. Beyond clinical practice, Zach co-founded the Level Up initiative in 2018, an education company focused on teaching students and new clinicians key skills in order to combat substandard and often harmful healthcare. In 2020, Level Up merged with Clinical Athlete, forming Kalu, a more comprehensive educational platform focusing on critical thinking, communication, and exercise, with a mission of wiping out harmful healthcare through empowering clinicians with the key skills to provide transformative healthcare experiences. Charlie is a physiotherapist, educator, content creator, and consultant for emerging health technology companies. He's a footwear designer, inventor, and athlete. Charlie is working to change the paradigm around how people understand and address pain and other physical symptoms. He co-developed the Beyond Pain Education course with Dr. Howard Schubiner, MD. And now, healing chronic back pain, the active ingredients.
Hello, everyone, and welcome to this Lynn Health podcast, where Zach and I will be talking about back pain. We're very excited that you're here, and there's so much to talk about. I know in the marketing materials, there was something about the gloves coming off today, Zach, and I had a little laugh this morning, like you and I were going to take the gloves off and go at it. But of course, we're both physiotherapists, and we both work very deeply in this space, sort of in a new direction. So I think if the gloves are coming off, it's around this topic, right? And around the way this topic is being managed and talked about in the medical system.
Yeah, I'm really excited to be here. I think it's one of those things that can be a bit of a taboo topic, trying to kind of switch the dominating understanding of low back pain and low back pain management. So I'm grateful to Lynn Health for advocating for this. So I don't have to be that guy on my own. But I'm definitely excited to have an open conversation with you about, my own experiences over the last 7 years, studying and learning, unlearning, relearning, and helping people, because that's what it's about.
Cool. And so I think maybe it's important to set the stage here, because the larger social narrative around back pain is that it's related to injury and tissue damage. And it's, the old ideas that we can somehow predict back pain based on MRI scans and things like that. And you and I are, as I said, working in this new direction where we're looking at not just back pain, but really all pain in terms of what we call this biopsychosocial model, where we're looking at the body, we're considering the person's psychology and also their social realities, because we know now from the last, 20 years of research that all of those things are important to consider when we're trying to help people understand and work through why they're in back pain.
I mean, that was mind-blowing to me. I mean, really 40 plus years, there is starting to be the emergence of people advocating for this, but it's just taken so long to catch on. And I think for me, one of the things that really tripped me up as a student was learning about things like phantom limb pain, which totally rocked my world. I think it's an example a lot of people know, but I think it helps people start to be more curious about the optimistic complexities of low back pain and not being such a linear process where, exactly like you said, tissue's damaged, we feel pain, fixed tissue, pain gone. It would be nice if it was that simple, but it's not quite.
For sure. And while I think this idea can be a little confusing for people at times, and I hope we can shed some light on this today, I just want to start by saying this is a really hopeful an exciting time in the field of managing pain, chronic pain, and especially back pain, which is probably one of the most common ways that you and I see chronic pain show up in the clinic.
Yep.
I think, there's this interesting stat, right, that 80 to 90% of back pain resolves by itself within 6 weeks, regardless of the intervention type.
Yep.
So pick any intervention you want, and most people are going to get better. But yet, we know that 10 to 20% of people get stuck in this sort of chronic loop of back pain. And there are lots of reasons for that I think we'll cover today through some of these questions that people have asked us.
I think the biggest thing for me, and I would encourage anyone here that's live, like ask questions, anything you want answered so we can tailor it to you. Otherwise, Charlie and I can riff. I mean, we spent some time on the phone and we were going at it for a while, but I think the biggest thing for me has just been curiosity and ultimately just trying to provide the best care for patients is what's been guiding me. And so it's been a really fun process because like you said, it is a lot of reason to be optimistic with the management of this. So I'm excited to kind of dive into the gray, but give some practical takeaways for people today.
So we have a number of questions from people submitted before we started the webinar. Maybe we should just start with that and see where things go. Maybe just to remind everyone again, Zach and I are both physical therapists. So we were both trained in sort of this biomedical model. We're both sort of manual therapy oriented, which means we have a history of using manipulation and dry needling and fascial release and corrective exercise and a lot of these body oriented strategies that we used to think were what fixed people's pain. And we've made this massive shift in our thinking in the last decade. Not that we don't use those at all, but we're considering all of these other factors in the light of more recent research that tells us that those body-oriented strategies aren't always what help in the long term. So we try to hold the both end. We try to hold that the body is important, but also understanding that the brain, 100% of the time, is in charge of our pain. And maybe you want to clarify that, Zach, but for me, that's sort of my most important starting point is remembering that everything we do is sort of focused on the brain and the nervous system when we're talking about trying to help people move through.
Yeah, for sure. I think my one little caveat to that for folks sometimes where they can run into trouble is feeling like they have like responsibility or they failed because they can comprehend that the brain plays a large role in it. And so they can cognitively understand that pain isn't this neat linear process. And yet that doesn't make all their pain go away. So you're spot on in this like complex interplay of brain, nervous system, body, environment. It's all of these things and how they're kind of relating to each other and interacting with each other. And so, being able to explore that together would be great. And I think that can almost lead us to the first question to set the stage, which is like, so let's say you gave a great example. And I agree, for a lot of folks, majority of folks with acute low back pain, odds are things are probably going to end up pretty good. Probability wise, things tend to do well, but for those individuals that it's just not getting better, 6 weeks in, they're coming in, Charlie, like, should I get an image? Like, I'm worried that things aren't getting better. You said things should be getting better in about 6 weeks, but they're not getting better. It's 8 weeks now. It's 10 weeks now. Do I go get an image?
Yeah, it's always a great question. And as with most things, the answer is always, it depends, right? And we know that radiology has amazing definition and clarity and can show us in great detail what's happening in the body. We also know from the research those things that an MRI scan can see or any other radiology can see are mostly just normative findings. That means these are things that happen in almost everybody, and they're normal processes of moving through your life. And so in the face of that, sometimes we run the risk of calling things out and those things being a red herring, like a bulging disc or a degenerative change or changes around the facet joints. Some of you on this call certainly have had MRIs, I'm sure, and have heard these terms thrown around, stenosis. These things happen with great regularity in people with no pain. And so we have evidence that when people are sent for those images early, because they almost always find something, the fear tends to go up significantly. And the fear, turns out, is what tends to drive the symptoms, not so much what we see on the scan. Do you want to jump in on that before I share another idea?
Yep. Yeah, I think my take on that, because I'm familiar with the, negative prognosis of what happens. Like the likelihood of a negative prognosis goes up when we get early imaging for low back pain and low back pain in general. And I think you're right. It does create a lot of fear. And I think for me, my interpretation of that is it's the fear that drives a lot of this avoidance, deconditioning, apprehension, hypervigilance of needing to be super careful, all of these different things that can kind of manifest in different ways of either perpetuating or increasing pain through some of these things. So I think that's always, I think, the biggest challenge is trying to acknowledge that it's totally reasonable to want imaging. It's easier said than done when you're not the one dealing with this ongoing low back pain. But it's also, like you said, trying to place in the bigger picture how quite normal some of these things are, quote unquote. The example of getting gray hairs. We don't freak out about that, but we have degenerative changes on the inside, and all of a sudden it's a whole scary thing, which creates all of these secondary things that can drive some of this disability, disuse, and pain.
Right. Yeah. And of course, I've had clients like you probably have. I'm thinking of a professional CrossFit athlete I was treating at one point who I started seeing because she'd had this recurrent pattern of back pain. And we know that once people have back pain, there's this pattern of recurrence if we don't sort of get to the core of why the person has back pain. And she'd never had a scan of her back. And she always assumed that there was something wrong with her back because she'd been training so hard for so many years for her sport. And she finally got an MRI and it was so clean. It was like the cleanest MRI. There was nothing happening on her scan. So for her, that was amazing to be like, wow, I always assumed I was damaged, but I'm not. And she moved through that really fast. And I think for her, it was a really important part of her process. For other people, there are going to be things that show up, and it's important to seek out a clinician that's sort of operating with from this place of the latest evidence and can weigh in on that scan in a more thoughtful way, right? That's not just going to jump to conclusions and blame things that maybe aren't responsible.
Yeah, and I'll say just on the imaging topic too, because I've had personal experiences. My sister-in-law, was starting to get low back pain. She was a new mother, ridiculous, radiating symptoms down her leg. And, my wife and I were both physios and we're like, okay, like acknowledging it's scary, like let's calm down, let's try some of these different things. Like nothing was touching it. She was going to a local physical therapist. Nothing was touching it. And she was getting progressive symptoms, like progressive neurological symptoms. And ultimately she actually ended up, she had cortisone injections. Nothing happened. She ended up getting surgery and she had pretty severe, bulging disc, let's say, but, that's a rare case. That's usually not the norm of how it plays out, but it's also acknowledging that can happen. I would say to those people out there that are wondering about surgery, I would say the majority of the time when people come to me, there's probably like at least 75%, like a large majority of things they haven't done or tried to really move the needle in a positive direction. And so I think for a lot of people, there's really so much more we can do to reduce the need of the likelihood of getting surgery and get them on track. But I think it's a lot of addressing beliefs, kind of being curious about certain things and being open to kind of maybe reframing their thoughts on certain things.
For sure. I want to try to share my screen real quick. So this is a study from 2015 that looked at 3,300 people. That's a huge number of people that had no pain. They had no back pain. And then they looked across the lifespan at different decades to see what percentage of these pain-free people had positive MRI findings. And this is a study I share with people a lot because it's kind of staggering to see that by the time someone's my age, I'm almost 50, that 80% of us have degenerative change in our discs, bulging discs, facet changes, right? These are huge numbers. And notice also that the numbers continue to increase as we get older, even though we also have data that the prevalence of back pain actually decreases as people move out of their 40s and 50s. Did you want to comment on this study, Zach, before I share one other image?
No, I mean, this was a pretty rocking study in terms of eye-opening to challenge kind of the status quo. And, again, like I think for my own lessons is it's the caution of these is not disvalidating the role of structural changes, because I think that can be kind of the swing when we see stuff like this is like, oh, imaging doesn't matter, where, but in this way, it's so optimistic because we understand it's not the whole story. We understand there's so many people that have no symptoms that have some of these changes. So that's just sort of my 2 cents on
Totally.
that.
I'm like so not a research person, so I feel like I'm kind of nerding out here. But I just want to say, like, we have this great research that the prevalence of structural problems causing pain is between 1% and 5% of people with low back pain. It's extremely small. And this is even true with people with acute pain. New onset pain or recurrent pain, the risk of something structural is extremely low, though we're treating people in the clinic as though everybody's injured or damaged, right? And this is what we're trying to shift. So I just want to show this image because when I was 20 and I had a herniated disc in my back that I didn't have surgery for, that resolved on its own. And I always wondered, like, where'd it go? Why do I feel better? And, I haven't had pain in 30 years, which was always really weird to me until I saw these studies showing that, 60 to 80% of people have this spontaneous resorption of disc bulges and herniations within about 6 months. And this is miraculous to think that the immune system can go in and clean this up and wall off the disc. And there's this constant sort of remodeling going on in the spine, especially if we can get people active and moving in their lives and moving through this sort of danger alarm of pain and getting back to living. So I like to share this too, because I think it's really, again, hopeful and inspiring.
Yeah, absolutely. And I'll second that. I've worked with several patients that have had, literally the one story is like imprinted in my mind is a young mom coming in, didn't meet with the physician. They just sent over the MRI, and literally at the bottom in quotes, it said obliterated disc, and she's sobbing. She's like, oh my God, I have 2 young kids. I'm never going to be the same. I'm going to have to get surgery. Like, lo and behold, she crushed it. It took time, took like 6 to 8 months till she was like fully back to doing her thing. But I mean, just the night and day transformation is unreal. And I think that's what we have the power to do as medical providers is shift that where we can really help dull. I call it realistic optimism. It's not trying to blow smoke. It's, being sensitive when we need to go in and maybe intervene a little bit more. But for a lot of people, there's so much we can do to move things in the right direction. And unfortunately, I think a lot of our training traditionally kind of doesn't really set us up to succeed with that, if I'm being totally honest.
You and I have had to do a tremendous amount of unlearning, haven't we? After years of paying thousands of dollars for continuing education in this direction, to be like, oh, I need to actually be looking over here.
Yep.
Okay. Yeah. And of course, we have to do that first to be able to support people in doing that themselves.
Yeah, for sure. I think we're getting some good questions, so maybe we can take turns. I can ask you, you can start off. So just starting back up from the top, there was one that I think is a great talking point. So, okay, Charlie, I'm a patient coming in, got my low back pain. I read it's just because I have a weak core. I don't have core stability. If and when, what is your role of doing core exercises? Do you do core exercises? And what's your take on the application of, core centric types of exercises? And this is, I'm really curious your perspective on this, and then I'll share mine.
Yeah, I had a really good experience doing core exercises when I, as I mentioned, had a herniated disc in my 20s. For me, I felt like it was really important. And looking back, I realized that's because I believed it was important. That's because to me, the clinicians I was working with, it just helped me feel safe, right? It reduced fear. It gave me some feeling of control. My feelings on this have changed a lot over the course of time. And now I tend to use, first of all, like, if you ever ask anyone to define what the core is, you'll get 100 different answers, right? Like, what is the core?
Yeah.
What are the core muscles? So I'm not saying there's not a place for that, but I tend to use them when we talk about performance And of course, aesthetics. I think they can be really relevant and helpful in those cases. That said, there's a very poor correlation between the core and pain. I have people that have the most ripped six-pack abs, the strongest human beings you'll ever see in your life, that still have low back pain. And then, of course, there are other people that are deconditioned and don't have a six-pack or whatever you want to call it, or aren't strong in their core, and they don't have any back pain. So this sort of old myth, I think, is dying hard, but I kind of hope it's dying a little bit. But that said, if people really feel like they believe like this is going to help them, then I'm game for like giving it a try and seeing how that goes. So I don't have a hard rule around it. What about you, Zach?
Yeah, I'm definitely more flexible than I have been on it because I was taught in the camp of like, don't ever flex your spine, core stability. If you have back pain, that's why, and just unpacking that a little bit. Look, so, first things first, we know there's so many different things that can help people manage their low back pain. Core, quote unquote, exercises can help with that. My concern, or the way I apply them, first off, the concern is that I think it ends up feeding into this hypervigilance around, oh my God, I have this back pain because my core muscles just aren't strong enough or firing in the right way. So you have people kind of obsessing about needing to make sure this small muscle in their spine is firing before they do something, or walking around bracing their core, or I work with a lot of power lifters and they are fed into a lot of this like core stability, and they're squatting hundreds of pounds. And I'm like, look, like your core is clearly really strong. So I think in some cases it can actually feed into pain mechanisms because it's creating all this tone and tightness around the low back. And I think about Louis Gifford, who is a true pioneer in the pain field. And he kind of talks about like thoughtless, fearless movement. And so that's sort of my paradigm around utilization of movement and exercise. I want to get people moving. I want to get them exploring ranges of motion, because oftentimes they've been so protected that they become deconditioned and sensitive to all of these other movements. So then when they do it, doesn't feel good. And then it feeds into that and they stop doing it. And so we need to find ways as clinicians to create a safe environment for them to explore movements, to do different things, get out of these sort of just like rigid movements. That being said, like you acknowledge, if someone is really gung-ho about doing it, it's really important to them, fair game. We can integrate it in. I think it's about just shifting the narrative of why we're using it and how we're using it. And it can be a part of it. But yeah, I've definitely approached it with more of this kind of, let's get people moving. Because oftentimes it's that sort of holding on to this very rigid application of it that can, I think, create more issues than solutions.
Yeah, well said. I think, we have research that general movement performs as well or better than specific movement, specific corrective exercises in the clinic.
Right.
And if you can find a way, the core is working with every movement we do.
Right.
If you do a squat or you bend over to pick something up, that's a core exercise.
Yeah.
Right.
Yeah. And then just the one thing I just reminded of is the benefit of utilizing something like, if you wanted to use a core exercise or a reframed core exercise or more global strength training, the benefit is in the trust, the implicit trust it's building. We want to be able to give you confidence to move. It's just confidence that it doesn't need to be done perfectly in this exact way. Otherwise, we're going to be doing damage or creating more pain.
Right. It's important to say, like, anything that reinforces fear, even if it's not intentional, is going to play back into people's pain experience most of the time. Yeah. So you can have the same recommendation, but one is loaded with fear and one is not, and you're going to have a very different outcome with those two. All right. Next question. The psoas muscle is like so trending right now, isn't it? Like everybody wants to talk about the psoas muscle.
Zach, it's been trending.
Yes, it's been trending. So can the psoas muscle cause low back pain and abdominal pain?
So look, again, I think the biggest thing as a clinician is the humility to say that I don't think we can with 100% certainty say something is or isn't. Like, could a psoas be contributing to a pain experience? I guess theoretically it could. I think my understanding of it now is that it likely isn't probably as important as we thought it was. Coming from a guy that literally used to have my hand going into people's abdomens to, release, quote unquote, a psoas muscle that was overactive, pulling on the back and creating back pain. We know that doesn't really check out in terms of what it's not doing what we thought it was doing. And I think it's similar to the core issue where it ends up feeding into this sort of hypervigilance around it, where, again, like, we're going to do things that will generally, hopefully, open up the hips a little bit. But I would approach it from more of as people gain more trust, as people start doing movement, some of the general tone of our abdominal muscles will start to go down, and maybe we see a decrease in pain and symptoms. But it's definitely not something I try to make a stink about. It's definitely not something that I usually give too much credence. But that's just want to acknowledge people if they feel that that's important. It's a discussion to be had. I don't want to just throw it out the window, but yeah, definitely not something that I spend too much time on.
For sure. We could probably do a whole webinar just on the psoas, but for those of you that know it, it's not really a hip flexor. It's not a primary hip flexor. People talk about it that way. You could say it has some relation to breathing. You could say it has some relation to stability of the hip and stability of the spine. Just to flip the script here, I like to really think about these dysfunctional things that we see in the body, or these tissue changes that we see in the body, like how people are breathing or held tension in certain muscles. I like to orient to these as the result of a nervous system that's in danger alarm. So the psoas isn't ever causing pain to the brain. That is the reason that you have pain. The way it works most of the time in my mind, my conceptual model, is that when the brain's in a state of danger alarm, it will send an output and create some physical changes in the body that we as clinicians can find and sometimes treat. If we pathologize those and we make them scary and dangerous, they don't tend to help all that much, unless the person has a really strong belief that that's going to help. But it's important to remember that a psoas that is different, has a different resting state when you're in pain versus when you're not in pain, isn't the cause of the pain. I think that's probably the more straightforward way to answer that question. Does that resonate for you, Zach?
Yeah. So why don't we go, because this one's real good. I'm going to read it. All right. So I have degenerative disc disease. My neck is completely fused, 2 surgeries, and I'm starting to get pain and pressure above and below the fusions. I have almost bone on bone in a few places in my lower back, and I'm trying everything to avoid surgery there because I found that it helps for a little bit, but then more surgery is needed above and below fusions a few years later. I used to be on pain management, but don't like the side effects of the higher dose drugs, so now I just live with the pain. I'm still trying to work, but it's getting extremely difficult, and my mental health is also suffering. What can I do to feel better and avoid fusion surgery?
Yeah, you can sort of hear in that question like this spiral that develops when people have gone through a surgery and then another surgery, and then pain shows up somewhere else, and it almost turns into a little bit of whack-a-mole. So first of all, I'm sorry that you're dealing with this, having already gone through these 2 surgeries that I presumably were supposed to help the neck pain, and now dealing with this low back pain. There are a few things in your question that I want to just mention. One is the idea that I think has been spread by the medical system that when you have a fusion, and doctors will often tell people this directly, you're going to have damage above and below the fusion. There's this sort of prediction that doctors will do that we're doing this, and you should know that you're going to wear out above and below, which you can imagine causes a tremendous amount of fear for people. Whether it's true or not, it often leads to more pain. The other one is the idea of bone on bone, which is another comment that I find clinicians throw out fairly often, which isn't really how joints work. I'm not going to say there aren't times when people have very thin cartilage or damage to their cartilage that leads to joint pain. But that term, again, thrown around too loosely, causes this image in our heads that the bones are just bumping against each other and like damaging each other all the time, no matter what we do. And so wrapped up in this question is some of this fear language that I think is really important to address. And I'll just like simple answer to your question, because we're here, as part of this Lynn Health webinar. This is why we're building this platform, is to support people in this situation with really complex medical histories in getting clarity about what's true and what's not true, and then sort of supporting them in learning the strategies to be able to figure out, like, what do I need to do? What is this? Is this a body damage problem? Or is this a fear problem?
Yeah, or a combo platter, of a bunch of different things. And I would say, for this individual asking this question, acknowledging the fact that it obviously sucks that it's gotten to this point. There's definitely a lot of clarifying questions I would have, but I also look at this and I see, well, I'm guessing there's probably a lot of things we could do to move things in the right direction. And I think my approach, regardless of, because look, we understand you got a fusion at a certain level. We understand you're having low back pain and potentially heading towards surgery in that route. So we can even say that there could be some structural damage, but is that going to prevent us from finding ways for you to engage in your world in a meaningful way? And I think that's really the approach that I tend to take, is we can find ways to do things that are more body centric, exercise wise. But if this person doesn't like exercise, we don't need to force exercise on them. But when you talk about things like mental health suffering, what that says to me is we need to find ways to get this person to focus on, it's so easy to spiral into the can't spiral of like, I can't do this. I can't do this. If I do this, it's going to flare my back up. If I do this, it's going to lead me to surgery. And again, fair to feel that way. But my challenge would be to try and find things that you can do. And I'd be willing to bet a lot of money that there are things currently that someone is not doing that they can start to do. And, that might mean riding on a stationary bike for 5 minutes a day. That might mean FaceTiming and calling friends and family that you haven't been talking to. Like, there's so many ways to engage in your world that can help you start to just build more confidence in what's possible. And it's this sort of like 1% better everyday mentality that I tend to take with these cases, acknowledging the complexity, but still moving forward because we understand what we know about structure. It's not this one-to-one correlation. So, hey, if there's no progressive neurological symptoms or like medical urgency, let's find ways to get moving and getting you engaging in your world. That would be my advice.
I'd like to say, like, movement isn't the goal. It's like the process. Like, it's the way out. And when we rest too much and we avoid, that's what tends to cause more problems. But I wonder if we can skip ahead just here a little bit to this other question that I'll pose to you. Maybe we can talk about it. I started with symptoms 2 years ago. And at first I was able to still do everything I wanted with a little discomfort. But about 5 months in, I did this 4-hour car ride and sat in a metal chair for about 3 hours. And the next day, the symptoms got significantly worse. And since then, sitting has been really hard to do. The MRI shows degenerative change and a stage 1 spondylolisthesis. Maybe we don't have to answer the question, can I become symptom free with this method? I can say that there's always an opportunity to down modulate or reduce symptoms. Some people do become symptom free. We can't always promise that, but go ahead and jump in, Zach, if you want to.
Yeah. See, like, this type of case is like, this is what gets me excited as a physical therapist. I'm like, oh my God, like, I feel like we have so much things we could probably do. And like you said, I generally don't like to promise people symptom free, especially if it's been dealing with it for a couple of years, but it's absolutely a chance. And I would say confidently, you can definitely reduce the symptoms you're having in a really significant way, if not totally gone. But again, it's a process. I would say here that I actually find the MRI very optimistic. Acknowledging that there is some of the structural changes. Sure. I don't know how old you are, so I don't know the normative data for like if you're 40, 50, 60 and how normal some of this disc degeneration might be. But that being said, you had something we know sometimes for a lot of folks, prolonged. It's not even sitting that's an issue. It's the static posture. So being in the same posture for a prolonged amount of time, that can make that can make things a little cranky with back pain. And so when you talk about a 4-hour trip followed by 3 hours in a new chair, whatever, like to me, that kind of sounds like something that could flare up a little bit of pain for this case, not necessarily, but we see that rationale. I think there's tons of things we can do. It sounds like things are probably just more sensitized and flare up, like Charlie was talking about, trying to find this understanding of how much of this is kind of starting to become conditioned because we're not doing things, and then our body's becoming more sensitive to stuff. So I think the key here is finding starting points to getting you moving in ways that are feeling safe and low discomfort. Low to no symptoms is totally fine when we're starting to explore movements. Doesn't need to be totally pain-free. But my guess is there's probably a lot of different ways to get you moving. And again, just to emphasize, it's not so much that it's like, oh, you're just not strong enough, but it's the process of moving and exercising where all of these wonderful things happen from, a biological, psychological, and social type of perspective.
Yeah, I think it's great insight. We talked earlier about how pain is a danger alarm, right? Pain is the brain going into the state of danger alarm and then creating some output of muscle tension or whatever. The brain also happens to be very good at learning. And what's so interesting about symptoms is that the brain can pair any two things that it wants. So for instance, if you have a flare-up from sitting in a car and sitting in a metal chair, your brain will start to predict that every time you do that, moving forward, there's going to be a similar response. And it gets into this sort of habit loop. It's not your fault. You're not choosing it. It's the brain's sort of tendency to learn things that leads to this happening. And so as Zach's saying, helping people understand why they're still in pain, sometimes weeks, months, years after some innocuous incident like a long drive or sitting in a metal chair, is really important to help to reduce fear. The other thing that I really like to spend time doing that we haven't talked about much yet is trying to make connections between the onset of pain and other things that might have been going on for somebody. So for instance, okay, we can acknowledge that you sat for 4 hours. There's nothing, physically dangerous about that necessarily. Sitting in a metal chair, like I wouldn't want to sit for 3 hours in a metal chair, but I wouldn't worry that I was damaging myself. The questions I usually move towards is, tell me more about the nature of that car drive. Who were you with? Was it stressful? Who were you going to see? Were you in conflict with the person in the car? Was there a snowstorm? Like, what were the sort of other stresses that might have been present that could have made that 4-hour drive different from maybe another 4-hour drive that you did at a different time? And if we can start to understand and make meaning from these other triggers, instead of instantly jumping to, oh, this degenerative change in my spine is what's causing this, then we have an opportunity to sort of really change the paradigm for people. And of course, that leads to getting them moving, but it also leads to hopefully this like general reduction in fear when they understand why this is happening to them, right? Seemingly out of their control. I think that leads into like these other strategies. And there was a question here about somatic tracking for pain, because as people start to understand that pain, maybe their back pain isn't what they thought it was, and they open up to the idea that there are other things they can do beyond starting to move again, somatic tracking is a great strategy. And for those of you who don't know, somatic tracking is just the skill of being able to sit with and observe the physical sensations in your body with curiosity, without judgment, without making up stories and going back into fear thoughts and spirals, and most importantly, without trying to change it, which is really hard to do because everybody wants their back pain to go away. So this skill of somatic tracking or sitting and observing the symptoms can be really powerful after you've established a certain amount of safety. And so this question is about, can I use that when I twist or bend? Can I use this strategy with movement? And because most people have done it sitting in a chair or, visualizing, imagining, doing it statically. But as physical therapists, we use movement all the time. And I'm always using these types of strategies while people are doing things, precisely because the brain is pairing pain with sitting, because the brain is pairing pain with bending forward, which the doctor and the physical therapist said were dangerous, because the brain is pairing with these other movements. We need to go through this process of sort of gradually exposing people to these in spite of the fact that they have some back pain, doing a lot of reassurance and gradually helping them to unpair these two triggers.
Yeah. And one thing that just reminded me of, Charlie, so a good way for people out there listening. So like, let's say bending forward is a trigger for you. This is a crude example and a little bit oversimplified, but also works a lot of the times. But I'll have this individual, and bending forward, it recreates their symptoms and their pain experience. But maybe we get on the table on hands and knees and we just do some gentle rocking the hips back to the heels. You're flexing your spine in this instance. You are doing lumbar flexion. You are doing the thing you thought was dangerous and creates your pain. Yet in this different context, it's not triggering this pain experience. And so like Charlie's saying, we're giving our body this cue that, hey, like we're doing this and it's not triggering. So maybe this isn't a dangerous thing. And it starts to build more implicit trust in these things. And so that would be my advice to you out there. Anyone listening to this, dealing with pain that's tried things, is like being curious about the things you think you can't do. And that's where working with a physio of this sort of paradigm can help you find ways to interact in your environment that probably can help reduce that trigger and reduce that cue by giving you other ways to move, other ways to explore maybe that movement, a similar movement, just in a slightly different way or a slightly different context, can be such a powerful, powerful treatment.
Absolutely. Yeah. And I think the one thing that we, when I'm describing this process to people that Zach, you and I do in the clinic real time with people, but also this platform sort of helps to deliver to people, is this menu of options. And the first one is, let's understand how pain works. We've talked about that a lot during this talk. Second is, let's gradually expose people to movement again and reduce fear so that they can be back in their bodies and show their brain, show themselves that they're safe. Somatic tracking, this somatic skill of being able to reconceptualize what the pain means, understand it in a new way, bust myths, let go of old thought patterns, and just be able to just watch the symptoms objectively, like you're watching a show. Also shows the brain that you're not scared or not as scared as you were, and helps you start to unlearn. And then the last strategy that we haven't covered yet is this sort of emotional part, which I think is missing for a lot of people with low back pain. People will often say, like, I hold stress in my shoulders, I hold stress in my back. That's because that's actually how it works. And getting people moving again is really powerful. Making connections between stress, and other emotions like fear or anger or sadness or grief or guilt, turns out is a really important way to defuse the brain's danger alarm. And I often say that back pain can sometimes be a distraction. The brain's trying to protect you from some big emotions that are threatening to surface. And so the goal then is to identify those, allow them to surface, and then be able to process through them. That sometimes is a backdoor way. I call it like a top-down way to turn off the danger alarm and get people moving again. And all of these strategies are things that Zach and I talk about regularly with our clients, and things that you can access through the Lynn platform.
I'll, real quickly, Mary asked, can PT help spinal stenosis? I think just to echo off some of what we kind of spoke about earlier, I will say, well, first off, short answer, yes, 100%. Spinal stenosis is not a death sentence by any means. Obviously, it's a spectrum. I've not really seen anyone that has such intense spinal stenosis that they're having like intense neurological symptoms per se. But I just had a virtual consult 2 weeks ago with 75-year-old woman. Stiff neck, little bit of some on-off radiating symptoms into her upper trap. She ended up getting MRI before we had consulted. Because I likely would have said, given what's going on, I wouldn't recommend it. Because you're 75 and odds are there's probably going to be some mild to moderate degenerative changes and stenosis given your symptoms. And lo and behold, that's what was found. She was scared, reading the imaging, she was concerned about like, oh my God, I have spinal stenosis. Am I ever going to be able to recover? Much, Charlie, to like you said earlier, like I have this disc injury. How did I get better? Where did it go? I've had patients say that, like, how is PT going to help if you can't fix the stenosis? How is PT going to help if you can't put the disc back into place? And that's where, whether you think you can or you can't, you're right. And it's corny as hell, but it's honestly true. Like, if you don't genuinely believe that you have the opportunity to improve this situation, it's probably going to hinder our progress. And so I would say the first thing is we need to be able to acknowledge any concerns or fears about the structural contributions, but we need to be able to reframe it in a realistically optimistic way where we know it's not a death sentence. We know people can do really, really well with this quote unquote diagnosis, which is super common for these different age cohorts. But the most important thing, and one of the active ingredients, is getting moving, reframing some of our understanding of this. Is there maybe going to be some joint limitations and range of motion and stiffness and stuff like that ongoing? Sure. Like, that could definitely be a thing, but it doesn't mean that people are doomed to live with pain for the rest of their life. And I think that just like genuinely believing in that, like, belief is a hell of a drug. Let's tap into that natural medicine cabinet we have, and realistic optimism can physiologically help us so much with low back pain.
I love the idea of the pharmacy in the brain. Yeah. I pull that one out a lot. Yeah. We have all this stuff in our brain. We just need to find out how to tap into it. And of course, exercise is an amazing way to do all of that. That's sort of a nice seg into this last question. If I can squeeze in this one last question that relates to, in this case, 42-year-old who's had chronic pain since 29. No one's ever found anything wrong with the back on X-ray or MRI, which is amazing. Like, we love to have that information. Lots of PTs and other clinicians have blamed it on hypermobility, which means that your joints move too much or you're too flexible, which in my mind is a false association. Even more so, I would say, than core stability, and things like malalignment. And I like to bring out in that case the idea that we grow like trees. And we are not meant to be straight and perfectly symmetrical. We are organic. We all have lived different lives. We do different things. And so as a physical therapist, I don't put a lot of weight anymore on misalignment because it just doesn't play out in the research as being that important. So those are two things that probably, because you believe them, then they are going to be driving symptoms. They're going to be creating fear and thus driving symptoms, but we're focusing on the wrong variable. And it's important when you've tried these things and they haven't worked to recognize that you've tried them and they haven't worked. And when you see that, there's a reason for that. And I appreciate you saying that you're on a hamster wheel and you're feeling like maybe it's time to go do something different. I would strongly encourage you to move out of that old model and start thinking about this a little differently. And I think you're going to do really well. Yeah.
And just to follow that up again, it's tough, right? Like, we are, hopefully medical practitioners are well-intended when they're telling you that your hypermobility and misalignment is causing your pain. But like Charlie said, A, it's unsubstantiated, doesn't hold up in the research. B, it ends up creating more negative side effects through unnecessary fear and anxiety and worry about hurting yourself, which is totally reasonable to feel that way. That's literally what you've been told by medical providers you trust. Like, it would be weird if you didn't feel that way. But I think what Charlie is saying, what I would advocate for, is just trying to empower you a little bit to, I think we oftentimes are on this holy grail quest of finding the thing. It's my hypermobility, it's my misalignment. And again, reasonable to want to find that thing. But I think you're onto something here, because like, exercise can be a beautiful thing. But for me, it wouldn't necessarily be about the exercise. The intent of it and the relationship wouldn't be to fix your hypermobility, to make you more stable, to fix your alignments, to get you stronger. Like, you don't have pain because you're not strong enough. The exercise would be about the process of finding ways to engage in your world, finding ways to move that can start to build this implicit confidence, get you doing more things. Are you going to get stronger in the process? Likely. Yeah. Hopefully, will the pain reduce in the process? It should. But I tell people this too, especially when folks have been dealing with pain for a decade plus. It's hard to, obviously we want pain to be gone ASAP. But my challenge to them is, hey, like, let's actually focus on, like, if in 4 weeks from now, like, here's what you're doing now. If we can be doing like 2 times that, or if we can be doing more than what you're doing right now, and your pain is like the same, maybe a little bit better, like that's a win. You know what I mean? So I think it's reframing what progress means. I think in this case is just the realistic optimism that there's probably ways you can move to build more trust and confidence in your body, and all the wonderful things that happen as a byproduct of it. And again, like having trust that you're not, you might have hypermobility, but this is not a thing that is like inherently dangerous at the gym. More so than anyone else. It's more about preparation, making sure we're conditioning ourselves the right way. So, but that fear is very pervasive, so stay patient. You got this.
I love this last question about PT making people feel worse. And of course, we have a reputation, right, of PT standing for pain and torture or physical torture.
Classic.
Classic old school mindset of like, we just need to push through it and force through it. Of course, I've been guilty of this in the past. And there are situations where this idea of pain inhibiting pain can actually be sometimes helpful. Dry needling is a great example of that, where a new type of input or new type of discomfort can interrupt an existing neural pathway or new existing kind of discomfort. That said, PT making things worse happens a lot, not always because the PT's on purpose trying to hurt someone, but because it's not the right thing. And the brain and nervous system know that. And there's this inherent wisdom that people have when they're doing something and it's consistently flaring them up. It's really important to listen to that. Your brain knows whether this is right or wrong. Maybe because the PT is using a lot of fear language. Maybe because it's just not fun.
Maybe they're they're trained in like doing just McKenzie methods. So they're just doing a lot of different extensions, but maybe they're super sensitive to that, or they're all core stability and maybe your body doesn't like that. So it's, a combination of all those things. And I would agree with Charlie here that it's, oftentimes you need to be able to listen to your body, and hopefully the PTs you're working with have enough humility to recognize that the approach they're trying may not be best suited for your unique needs. And if they can't pivot and be flexible, then you should probably try and find a different provider who's going to have more humility and curiosity and genuine interest in making sure they're doing everything in their power to use your own expertise to drive progress.
't you, Zach, for making time to join me today and take the gloves off around this issue. I think we gave it a good punch in the face. Thanks, everyone.
Thank you, everyone.
Thanks for tuning in to the Rethinking Pain podcast. For more information about steps you can take to reclaim your life from chronic pain, visit us at lin.health.